special guest speaker this morning. We're very pleased to welcome Dr. Wendy Chen on behalf of the Women's Council and specifically actually as part of the Residence Women Council invitation for today. So I will say Dr. Chen, many of you know her by reputation or know her in person, but she has really a wealth and breadth of experience to her credit, really being so early in her faculty career. She has degrees in biochemistry, Eastern Asian languages and culture, public health, and physiology. And all of that predated her medical school time at the University of Cincinnati College of Medicine. She subsequently completed residency training at the University of Pittsburgh in plastic surgery. And while doing that, did research time in eye microsurgical allotransplantation, and then did concurrent elective training time in gender affirming surgery, both at Mount Sinai and at OHSU. So she then went on to a hand surgery fellowship prior to starting her faculty career. So she is currently an assistant professor at McGovern Medical School at UT Houston. Her clinical practice is at many places, but centers a lot at Children's Memorial Hermann Hospital around plastic and reconstructive surgery with specific expertise in hand anomalies, brachial plexus, complex extremity microsurgery, and also adult and pediatric hand trauma. So in the midst of all that, she has done extensive work and has really become a nationally recognized leader and champion in education and activism in surgery for diversity and inclusion. She has more than 30 invited speakerships, 33 peer-reviewed articles, and more than 200 abstracts and many awards. And much of this is around DEI in surgery, plastic surgery, and then evidence-based interventions to address challenges and goals. So Dr. Chen, we are extremely pleased to have you with us this morning, and we're looking forward to growing and seeing how we can continue to work toward our goals.
Thank you so much for that introduction. I've admired this institution ever since I was second year medical school at every stage. So it's really an honor to be here today. These are my disclosures. So I don't know about you, but I get multiple emails every day about diversity lectures at my own institution or nationally. And obviously I care a lot about diversity, but even for me, sometimes it's a little bit overwhelming and overstimulating. And I've been evolving this talk for 3 years. And sometimes I wonder, is it making an impact? Is all of this working? So for any person out there who's hungry for progress, frustrated, fatigued by slowness, or you feel like you're just one person, one department, you're not alone. So the business world has been at this for longer than we have, and they've found key reasons for failure to be fatigue, backlash, and denial of inequality. And when people feel like they're not making progress or not being supported, they give up. So today, I hope I can convince you to not give up. I hope to recenter this conversation on the why of diversity in academic surgery. I hope to share some numbers that will have a lasting impact on your perspective of social justice in academic surgery for our peers and for our patients. And I hope every person can come out of this with just one thing they can start implementing today towards implementing our culture, implementing a change in culture for our peers and for our patients. Hi. Okay.
Again, sorry.
And then I need to minimize this guy. Oh, that's better. I like that. Okay. All right.
Thank you.
Now, let's get back to this. That's my little wellness joke. Okay. So I believe the overwhelming vast majority of us in surgery are not only clever and motivated and known for being creative problem solvers. We came to this vocation because we're kind and compassionate. So I flatly refuse to accept that we as a group of people with these attributes cannot figure this out, because there's so many brilliant people in medicine and surgery. So I put out there in the beginning that I think that this is something we can accomplish. Oh, and I apologize, there might be some weird animation text issues because of the transfer of the format of the file, but let's get to some vocabulary. Diversity means a lot of things, some of which are more visible and some of which are less visible. In surgery, this has implications in terms of fair pay, fair promotion, fair evaluations, and opportunity in the operating room, as well as opportunities for those rising to join our ranks. Intersectionality is a contextual framework for examining how various complex systems influence experiences and opportunities. It includes your perceived race, perceived gender, how attractive, young, able-bodied you appear, and how these interconnected factors influence power, privilege, opportunities, or oppression. If, in terms of understanding privilege, you've never seen this quote, I think it's really helpful regardless of your politics. If you've never had a Supreme Court decide if you have the same rights as others, then you have some degree of privilege. Every time I give this talk, I review the most recent Supreme Court rulings. Suffice to say, in the last 12 months, if what is going on in those chambers has not impacted yourself or somebody you love regarding what freedoms you have about your body, your healthcare, your marriage, in which states, you don't have to refresh the ACLU website, you have some degree of privilege. And this quote really sums up the basic right of being allowed to exist without being questioned about your existence and what rights you, quote, deserve, and what cumulative disadvantages you may face. But there are many other forms and levels of privilege that go back to how we define diversity and intersectionality. You can be privileged in some ways and not in others. What is representation? I think of that as visibility. So in this example, when children read books and the reality presented to them, Latinx, Asian, African Americans are underrepresented, and animals who don't fill out the US Census make up almost as much as all racial minorities combined. And here's another lesson in invisibility and silencing. So media directly impacts how people see themselves in the world and each other. So if you don't know, in film, there's such a test called the Bechdel-Wallace test, and it asks whether in a work features at least two women with names who talk to each other about something other than a man in a conversation that lasts over 5 words. And if you watch films from like the 1990s and 2000s, it's kind of shocking how many mainstream films cannot pass this test. Avatar, Finding Nemo, The Avengers, The Little Mermaid. And so if you don't know, Gina Davis, who used to be married to a plastic surgeon, has an institute for gender in media that specifically does research on visibility of female characters in media and how they are portrayed. In differentiating between equality, equity, and justice, equality may not change the playing field very much. Equity accounts for systematic, structural, cumulative barriers that have led to different outcomes, despite perhaps similar or even greater talent or effort. And so that in a truly just environment, the systematic barriers are removed and there's true fairness. And inclusion is probably best understood in the context of exclusion. So at 6 years old, Ruby Bridges had to be escorted to first grade by 4 federal marshals. Brown versus Board of Education had been decided 6 years prior, the year that she was born, 1954. When she arrived at school, white parents pulled their children out from school, and all the teachers except for one refused to teach any children, as long as she was there. Her entire first and second years, she was the only student in her class taught by the one teacher willing to educate her. Every day on her way to school, one woman threatened to poison her food, and another held up a black baby doll in a coffin to a first grader. You know, she only ever ate food from her own home that she brought. Her father and grandparents lost their jobs, and the grocery store refused to service them. So for context, Ruby right now is 68 years old. So even if you exist in a space, have a seat at the table, it's not the same as tolerance, which is not the same as inclusion, belonging, and acceptance. So what is the why? Because checking the demographics box is not the why, even though right now, sometimes it feels like that's it, like just get the demographics box checked, you know? In my mind, the endpoint and outcome measure is patient outcomes. And that includes ourselves as physicians. I would like to be a healthy person with a long career, helping people, lots of people. we are also patients, so to speak. We also need health and wellness. And along the way, I think these two major goals include a safe and socially just environment and understanding wellness and burnout and the positive or negative impacts that has on recruitment, retention, and productivity. You got to put on your own life jacket before you can help somebody else. And secondarily, improving patient outcomes, satisfaction, compliance, disparities. Studies have shown that to achieve that goal requires a physician workforce that parallels the patient populations we serve, leading to better understanding of medical conditions and treatments with increased diversity of viewpoints, better teamwork, collaboration, and innovation, which has been proven in other professions as well as in medicine also. So do we have a safe and socially just environment? Spoiler alert, not so much, but let's learn together. Okay. So what are the current demographics in academic surgery? In terms of race, 2030 will be one of the first inflection points, and in 2045, the country is projected to be a Caucasian minority country. And it seems like such a long time ago now, that initial period of pandemic lockdown, we were just talking about it. And I think it's important to remember that just within the first few months, the APM Research Lab and Brookings Institution had already found that coronavirus had rapidly become the third leading cause of death in Black Americans, which as a physician and healthcare worker, I think is alarming. And it is insult to injury in terms of how frustratingly ironic that is, because the medical world has benefited so much from the unethical treatment of Black Americans with rare acknowledgement. For the study of gynecology surgeries on women and babies with neither anesthesia nor consent, with one woman documented to have experienced 30 surgeries without anesthesia or consent. The Tuskegee experiments misrepresenting the withholding of treatment. In 1960s, exposing patients to whole body radiation to study the side effects. The reason we know that fen-phen is unsafe for adults is because in the 1990s, they did experiments on Black and brown boys aged 6 to 10 without informed consent and withholding medications for underlying chronic conditions, cardiopulmonary conditions. HeLa cells from Henrietta Lacks from Johns Hopkins. That's how we have vaccines for COVID. Probably anybody who's done bench research has worked on HeLa cells with your little pipette. And because of her cells, we have developed treatments for cancer, HIV, Ebola, TB. And if you happen to have needed in vitro fertilization, the research was built on those cells. This is especially sad when we then consider the subsequent understandable distrust of the medical system this has resulted in, compounded with the continued hesitation to participate in clinical trials and continued inequity in treatment and clinical outcomes, even if you are an elite athlete. So we just had this recent death of an Olympic athlete, and Serena Williams, if you don't know, she had a blood clot and they didn't believe her. So according to the US Census data, Black and Hispanic populations make up 13 and 18% of our country. Yet in this 2015 study looking at racial diversity in academic surgery over the course of a decade, they made up about 5% of medical student graduates, residents, and in every category of professorship, falling well shy of parity, without much progress to speak of. As far as I can tell, this study has not been reported since it first came out, now almost 10 years ago. In this 2021 article, a total of 800 division chiefs were identified at these university-based institutions across all specialties within general surgery. Again, the US Census numbers are down here for comparison. And as you can see, Black and Hispanic representation is pretty much not good in all positions, very poorly represented. A lot of 1%, 0% here in colorectal and cardiothoracic surgery. Interestingly, only trauma and acute care surgery had greater than 10% representation for Black surgeons. No divisions had greater than 10% representation for Hispanic surgeons. Despite this, non-white physicians care for over 50% of minority patients and over 70% of non-English speaking patients. Prior studies have also found that Black and Hispanic patients are more likely to seek out and feel comfortable with physicians who are also underrepresented minorities. Is a qualification? Is that the issue? So this article chased after CVs of presidents of ACS, ASA, AWS, and SBAS, and found that after controlling for age, the AWS and SBAS presidents' scholastic achievements, defined as these here, were comparable to the ACS and ASA cohort in 9 and 12 out of 15 metrics respectively. Things like publications, NIH funding, leadership roles, and that's after the presumed cumulative career disadvantage that they have lived through. So it's not a qualifications issue. In my own specialty, National Society of Leadership has had quite bad representation. ASPS is our national society. It's nearly 100 years old, and we finally elected our first Black president. And for reference, the American College of Surgeons hit that milestone in 1979. In one paper that examined trends over a decade, the authors noted a total increase of 0.3% and 1.7% in Black and Latinx plastic surgery faculty over the course of 12 years. So without accounting for the fact that minorities are a growing population, that means it would still take 8,800 years for Black and Latinx Americans respectively to attain parity in academic plastic surgery. This invisibility is why one of my colleagues here in the Pacific Northwest, anytime he drives in from home call, he feels he must wear his white coat while he's driving in at night for safety as a Black man. And his wife she worries about him every time he has to drive in the dark, because there are fewer Black men applying to medical school now than in the 1800s. And the percentage of Black doctors who are Black men, remains essentially unchanged since 1940. In 2021, a UCLA study found the share of Black physicians in the US has increased by only 4% in 120 years. So if you want to learn more about this, I really recommend you watch this documentary from this organization and support this organization. It's called Black Men in White Coats. And even just as a hand surgeon, hand trauma surgeon, and pediatric surgeon down by the border in Texas, this quote really rings true for me, that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. What about LGBT colleagues in academic surgery? Despite legal equality and rapidly changing public opinion, LGBT physicians still have different experiences than their colleagues. Let's remember that it was only in 1972 that the American Psychiatric Association depathologized the diagnosis of homosexuality from the DSM-3. And I think it's important to emphasize here the history of discriminatory care towards LGBT patients, who they are a minority population like any other, and they experience health disparities and lack of comprehensive data. In 2010, a survey by Lambda Legal investigated discriminatory care, defined as refusal of care, refusing to touch the patient or using excessive precautions, using harsh and abusive language, blaming the patient for their health status, and being physically rough or abusive. How many respondents experienced discriminatory care? 56% of LGBT respondents and 70% of transgender respondents. And that includes our physician surgeon colleagues, some of whom have told me they've driven 40 minutes out of their way to find a sensitive PCP that won't shame them. Somebody didn't go to an OB-GYN for a decade because of being shamed once as a young woman. And when I was a handful at UCLA, 100% of my LGBT patients had the same PCP, George Yen, my friend from undergrad, 15 years prior at UCLA. And so I think that's important to know that it affects us, our colleagues, our physicians. In 2010, 2,000 heterosexual medical students from 49 medical schools responded to a survey that aimed to measure explicit and implicit bias attitudes towards gay and lesbian people, as well as empathy and interpersonal reactivity. 45% of respondents expressed some explicit bias, but 82% exhibited some implicit bias against gay and lesbian individuals. Around 2014, there were studies that showed a third of patients did not want to be cared for by LGBT providers, and 10% of LGBT physicians were denied referrals based on their sexuality. In this survey of general surgery residents, 30 to 50% of respondents reported witnessing homophobic remarks. Over half of LGBT trainees concealed their sexual orientation. 12 to 21% experienced direct homophobic remarks, and 0% reported these out of fear or wanting to minimize the experience or sense of futility. It's no wonder that even as attendings in plastic surgery, in an unpublished study, 13% of faculty reported feeling uncomfortable bringing their significant other to departmental events. So, you finish residency, you finish fellowship, you got your job, and then you've gone through this, but your partner has gone through it also. And now it's like graduation, and you're sitting at the kitchen table and you're like, I don't know if you can come to the holiday party, can you imagine your significant other is rendered invisible by non-disclosure. Within plastic surgery, this unpublished data also shows that in parallel with regards to patient care, 19% of LGBT respondents reported witnessing discriminatory care, but looking at their heterosexual counterparts, only 6% noticed that LGBT patients were treated differently. This brings us to 2021. In this survey of 6,400 residents, 300 identified as queer. Discrimination was reported by 60%, harassment by 48%, including coercion, which, if you don't know the legal definition, is harm, threatened, if non-compliant with a sexual act. And bullying was experienced by 75% of queer general surgery residents. And these numbers are comparable to what the lay population experiences. Despite experiencing higher rates of mistreatment, queer residents were equally likely to report satisfaction with the decision to become a surgeon and symptoms of burnout as non-queer peers. However, they were nearly twice as likely to report considering leaving their program, and most alarmingly, twice as likely to have thoughts of suicide, 8%. This association with suicidality was no longer evident after adjusting for mistreatment. In the general LGBT population, at best, minority stress means extra energy expended to fit in, hypervigilance, and at worst have opportunity costs, adverse effects on personal integrity, self-confidence, and at worst, it can be weaponized against somebody or have serious mental health or health consequences. This is a project that I'm recently doing with some of our colleagues. And to not feel like you can be authentic until you're an attending, and even then there's an opportunity cost. Somebody got told our program already has a gay. How are you going to be different? And then one resident, in terms of bullying, their chief resident was like, I'm going to out you to your parents. And he was like, I'm already out, dude. Like, that's not going to hurt me. How about women? Women have made up over 50% of college students since the 1980s. And in 2021, not only do more women hold college degrees than men, in 2019, women comprise the majority of medical students in the United States. At the resident level, the ACGME shows that a third of surgical trainees are female, but those numbers don't hold steady. There are plateaus and numbers wax and wane. So just because progress is made does not mean that it is maintained. So when you're a medical student trying to become a resident, how are you seen by your letter writers? In this project, we worked with the linguistics department, and we found that nearly 90% of letter writers were men. But interestingly, female applicants were ranked higher overall, but especially if their sponsors were women. And what I found most interesting about our data is that the computer could predict the applicant gender with greater than chance accuracy based on the language used in the letters. Female residents, including but not limited to surgery residents, have been found to be evaluated more negatively than their male counterparts, including in this giant GME study of North America from 2018. And in the operating room, there's significant bias against female trainees with less autonomy in thoracic surgery and general surgery. PPE and surgical instruments are not made for women's faces and hands. And if you don't have a custom, properly fit lead, a study has proven that ill-fitting equipment can be the difference between getting occupation-acquired breast cancer or not. That's in orthopedics. In academic medicine overall, the concept that increased number of women in medicine will eventually bring gender equality is a notion held by men and not shared by women. And the visible inequality and lack of women on faculty and in leadership are seen as deterrents when institutions try to recruit women. Surgery remains a male-dominated field, and women are underrepresented in academia, awards won, and leadership positions. In general surgery, at the assistant professor level, women are 6 times more likely than male colleagues to intend to leave within 2 years. And the percentage of full professors in surgery that are women is increasing at a rate disproportionately slower than medical students and residents. Female chairs and faculty were more likely at university-based programs versus affiliated or community programs. And interestingly, their presence was not associated with proportion of female residents. In terms of the pipeline from 2006 to 2019, there's been essentially no change for trainees and faculty. There are fewer women on editorial boards, but there are 2 women now who have served as journal editor for JAMA surgery and for diseases of the colon and rectum. This is in contrast to internal medicine, where women on editorial boards range from 23 to 83%. And in plastic surgery, we're currently writing up a manuscript of qualitative interviews to understand why you have a drop off from residency to faculty, and then half of faculty women then further leave within just a few years. This impacts not only students and trainees, but as well as the faculty that remain in terms of gender tax and mentorship burden. In this article, breaking down by subspecialties, even in specific subspecialties where women make up 54% pediatric surgery and 44% of colorectal graduates, only 16 and 18% of division chiefs in those subspecialties were women. For perspective, in this article on Canadian plastic surgeons, their numbers really put us to shame. Over double the number of female full professors, 4x more female vice chairs, nearly double the percentage of female department chairs, and nearly double the percentage of people of color on faculty. More than leadership, are we safe in this place? We go to work every day and we spend so much of our time away from our families. 27 years ago, the Council on GME concluded that gender bias reflected society's values and was the single greatest deterrent to women achieving their full potential in this job. For context, that year was when the World Health Organization came into existence. After that year, Google was born, Facebook was founded. Now we all have iPhones as a prosthetic attachment to our bodies. And with that in perspective, how much has or has not changed for women in surgery? This is a really great video if you haven't seen it before from the Hip and Knee Society. They take quotes from the last 5 to 10 years and they have some male attendings read them in real time and for their reaction, like read them out loud. And it's really eye-opening for them to understand what the experience has been like for female colleagues. You know, did you go to nursing school before they let you go to medical school? What advice do I have for you as a resident? 2 words, birth control. You know, now that you're back from maternity leave, I guess you got to go make baby food with your boobs. Training women is such a waste. There's one quote that I got from writing an article on hand surgery, which was, how are you going to work when you're menstruating? And the interviewee was like, I'm menstruating right now. You know, like, it's fine. I do it every month since I was 13. So maybe it's a surprise to some and not to others, but medicine has the highest rate of sexual misconduct among the scientific fields. The academic workplace is surpassed only by the military, with the highest rates of sexual misconduct amongst all professions. Within surgery, sexual misconduct occurs at alarming rates, victimizing both patients and providers. In 2020, a study looking at the last 35 years found 125 faculty were accused of sexual misconduct, with 1,700 targets affected. 72% of these perpetrators targeted subordinates, 19% clinical trainees, 30% committed sexual assault, 56% sexual harassment. Half were allowed to gracefully resign, only 1 in 5 were terminated, and 40% remain in academia, just at different teaching institutions. So trainees are a vulnerable population. They rely on relationships with mentors and superiors for opportunities in research, in the operating room, for networking, and ultimately for fellowships and job placements. 30 odd years ago, Susan McKinnon found only 20% of instances of sexual misconduct were reported, and few studies have existed like this in surgery, and even few with granular descriptions. While instances of harassment are improving, this problem is still problematic, and professionalism in training and surgery should be a basic standard. In 2019, this survey of 7,500 surgery residents found that rates of all forms of mistreatment were higher amongst women, but alarmingly, similar to the LGBT study, 4.5% of residents had suicidal thoughts, and women were at risk due to experiencing greater mistreatment and greater burnout. These symptoms, again, data was corroborated in this well-known study from 2021. And so because we couldn't guarantee trainees a safe environment, because we can't manage what you can't measure or what you don't measure. So in 2018, I surveyed active plastic surgery trainees. I based the survey on one used in the military, and as well as some wellness studies from previous authors. And we found that 1/3 of female trainees have had sexual comments made about their bodies, and men were not excluded. 1 in 5 men also experienced this. Nearly 1 in 10 respondents reported unwanted touching and or sexual exposure, including 1 man. 2% of respondents reported sexual assault, coercion, again, coercion, including 1 man. And sexual assault and coercion were more likely experienced by non-Caucasians, which is a mirror of other professions. Women experienced harassment from all members of the hospital community, from patients to nurses, fellow residents, all the way up to attendings, but particularly from other physicians. As with the LGBT studies, trainees deferred reporting, citing fear and futility. And sadly, some people were reported to comply, to protect themselves, or to just get a hold of that opportunity. Wondering if anything has changed in the 4 years since I did that survey. We sent the survey again. Abra Shen from here is part of that project. There was improvement in women feeling prepared to address bias and inequality, but women felt unprepared to address sexual harassment. Women still felt their gender played a negative role in their career advancement. Compared to men, they still felt their gender experience diminished their ambitions and career goals, but the negative impact of sexual harassment and assault was improved. But there were still more trainees in 2022 that were considering to leave, and that was actually worse. Compared to 2018, less men and women are reporting these experiences, but 1 in 4 women and 1 in 6 men is still too high for this type of behavior in the workplace. In 2018, 6.8% of respondents reported unwanted touching. This more than doubled to 12.8% doing this last year. And I think that this is a reflection of people willing to report it more. And there were still forced sexual acts that were being reported. These findings are borne out in general surgery as well, with 80% of women experiencing discrimination, 43% experiencing harassment, and the burnout data is also corroborated. Are attendings less protected than trainees? If you think about it, as trainees and students, you might actually be more protected. And as an attending, you may continue to experience inequities or misconduct, not having paid leave, greater stakes for reporting conduct, loss of wages, employability, reputation, and the momentum that builds around a narrative that somebody is selling. Coincidentally, the chair and co-chair of neurosurgery at my institution came from Harvard as a package deal after the first and only female spine neurosurgeon refused a settlement payoff from the hospital, went to trial, which is exceedingly rare, and won $1 million lawsuit for a hostile work environment against the two of them. For her, that included being asked at graduation to wear a belly dancing outfit and dance on the table to show the female residents, quote, how to behave. She arrived at a coworker's party to see a blow-up doll with her face attached to it. She was told, why don't we leave this place so I can give you an oral exam? I imagine you naked all the time. One of the perpetrators sat on the credentialing committee and recommended to the committee that she be forced to undergo anger management training and required her to obtain outside psychiatric evaluation within 4 months in order to be reappointed. Out of the $1 million, how much was the surgeon responsible for? $20,000. And just like the data I've presented before, they just moved on to another institution. And it's really fascinating. What about students, nurses, PA staffs, and patient? What are the laws, protections, and guardrails there? Because they're part of our community and our culture as well. And people that I think as physicians, we should help protect. So working with a team of law students and a law professor, we essentially use the PubMed of law to query for cases describing sexual misconduct in a clinical setting between 2009 and 2020. Data on setting, specialties, survivors, perpetrators, and legal action were obtained, and the perpetrator's fate was determined by an internet search and classified as still in practice, in jail, or barred from practicing. Using these search terms, we identified 7,000 cases, 3,000 met inclusion criteria, and we sampled 100 of them randomly as part of our pilot study to see if we should look at all these cases. The 3 most common injuries claimed in court were non-consensual contact, sexual exploitation, and rape. Nearly half were in non-surgical specialties, such as, disturbingly, family medicine and pediatrics. 30% of perpetrators were surgeons or anesthetists, who were nearly 3 times more likely to harass coworkers, such as other physicians, nurses, and PAs. Whereas perpetrators in non-surgical specialties, such as peds, targeted their patients. In this version of this talk, I'm leaving out further description of the court proceedings, but the perpetrator's fate was clear in 47 cases, because I don't know if you know, but you can ask Google to hide a lot of information about it. And 49% were reprimanded with a jail sentence or revocation of medical license, but over half were still in practice, with perpetrators in surgery or anesthesiology over twice more likely to still be practicing versus not those in non-surgical specialties, 75%. So we need to radically accept that never events are occurring in academic surgery. Just as in surgery, in life, good enough just isn't. And I think of it this way. Let's say if you believe the sexual misconduct data I present, the LGBT data, this is one of the analogies I use. I'm sure everybody in this room knows what a free flop is. It's one of the most complex operations plastic surgeons do. And when a free flop goes down, it's a rare surgical emergency. It should be. In the hands of plastic surgeons, let's say at this institution, I'd say that percentage is exceedingly low, maybe 5% or 1%. But for this rare occurrence, is it okay for a senior resident or attending to not know how to manage a flap going down? In my residency, even a second-year resident with your little checklist should know how to get a patient into the OR with all the necessary supplies and humans within the golden hour of a flap going down. If we had a complication rate of 10, 20, 30%, 10% experiencing unwanted touching, 30% sexual comments about their body, would we just accept that and be like, I'm okay with that? No, I don't think so. So compared to the rare instance of a free flop going down, micro and macroaggressions occur every day. So back to what is the why beyond demographics? Just this week, in response to the affirmative action Supreme Court case, multiple news outlets have now given airtime to how this move could downstream impact healthcare. And the AAMC maintains that diversity, quote, literally saves lives. In 2023, not only is there a business incentive, there's a moral, professional, public health imperative for us to achieve equity for minority patients. And part of doing that is achieving equity for minority physicians. In other professions, it has been proven diverse teams are more creative, have greater collective intelligence, leading to better complex problem solving and innovation. When minorities are in a culture that permit them to thrive, performance and profits improve. Diversity is used to find opportunities, face challenges, and explore new avenues. All of these things sound like things that as surgeons are part of our identity clinically. So let's look at some deliverables. Okay. Within academia, this is a paper from Nature, an analysis of 2.5 million scientific articles between 1985 and 2008 revealed those authored by more diverse groups were cited more and had higher impact factors compared with homogeneous groups. And in parallel, in plastic surgery, this group found diversity of authorship defined as gender, institutional geography, which is a surrogate for cultural differences, and specialty of focus, such as relationships inside or outside of plastic surgery, was present in the most cited articles in plastic surgery literature. And that having both domestic and international authors was most predictive of citations, followed by mixed gender authorship. That makes sense to me, right? Like you want people on your team with different training, different skills, perspectives, and backgrounds. When I'm not sure about a decision I'm about to make surgically or clinically, I just reach out to somebody, somebody with different training background, more experience, Not only is diversity expected to positively impact the US healthcare system, multiple authors have concluded that continued underrepresentation of non-Caucasian, non-Asian groups will have a profoundly negative public health effect. Both the Institute of Medicine and NIH have long reported the potential value of diversity in maximizing health benefits of medical teams that bridge cultural and linguistic gaps. Greater diversity improves the accuracy of clinical decision-making, leading to higher patient satisfaction and resulting in improved health outcomes. Furthermore, student and faculty experiences of bias have a secondary negative impact on patient populations. Lack of minority representation in healthcare profession can compound inequalities. So it makes sense that the ACGME in their language, in their goals set out for training programs, has said that they want to try to match the workforce diversity and at least the research interests with the patient populations that we serve in academic training institutions. Conversely, when a UIM physician is an active member of their care team, minority patients have better compliance, higher patient-reported outcome measures, and an increased likelihood of participating in clinical studies. So race is a social determinant of health that surgeons of all subspecialties, especially those in academic institutions, cannot ignore in their daily consideration and practice. Specific to female attendings, this meta-analysis found female doctors spend 10% longer, 2 minutes, with patients during visits and engaged in significantly more active partnership behaviors, positive talk, psychosocial counseling, question asking, and emotionally focused talk with no difference in the amount, quality, or manner of biomedical information provided or social conversation. Gender has a highly selective effect on empathetic concern, with women displaying higher values. Clinical empathy is associated with improved patient satisfaction, adherence to treatments, and fewer malpractice complaints. Female physicians, on average, obtain more frequent informal consultations with colleagues who are more focused on reading clinical research studies and reviewing the patient chart when making clinical decisions. Perhaps that's why not only is there data that women have better patient-reported outcome measures and team communication, I think we all saw this Michigan data on how women may be marginally better surgeons with better outcomes, even with multiple variables controlled for. And in plastic surgery, Heather Furness has reported that female patients prefer female surgeons. In medicine, these authors found elderly inpatients treated by female internists to have lower mortality and readmission rates, and lower mortality of female heart attack patients when treated by female physicians. Medicare patients treated by female physicians had lower healthcare costs, fewer adverse outcomes, and lower chance of hospital-related death. Despite these findings, in these articles from just the last couple of years, the authors reported on a cross-sectional study of 40 million referrals to surgeons. Female surgeons received non-operative referrals more often than did the male surgeons, distorting the playing field of productivity, which we're all held up to, whether it's our views or whatever, what have you. And these authors in orthopedic surgery, the highest paid surgical specialty, concluded their data indicated it will take more than 200 years to achieve gender parity, leading to a notable loss in cumulative lifetime earnings. Women in this country have poorer health and higher out-of-pocket costs than women in other high-income countries. An American woman today is 50% more likely than her mother to die in childbirth, and the numbers are particularly worse for Black and brown women. Maybe with more female physician leaders, the health of American women might actually improve. And if we want to talk about money, let's talk about recruitment and turnover. One of the alumni at my residency used to say, when we graduate, we're all Ferraris, because there's a certain dollar value a surgeon brings to a community in terms of jobs and work that you keep inside a community. Out of curiosity, I looked up how much it costs to train a fighter pilot or a Navy SEAL. And fighter pilots are more expensive. They're like multiple millions of dollars, but SEALs are like $500,000. So that's like an amount of educational debt that I can relate to. And depending on where along the pipeline you lose somebody from academic surgery, let's say junior faculty, mid-level faculty, what kind of value are you losing from that person, but also from what they have to offer trainees? Who's going to teach the next generation to do my limb salvage if I'm in a car accident, or your family's breast reconstruction? In addition, the estimated physician replacement cost is 2 to 3 times the physician's annual salary and can be even higher in surgical subspecialties and could worsen as the projected surgeon shortage intensifies. In addition to the business side and clinical outcomes, of course, the reason we are all here in medicine is the humanistic side. So if you believe the data, the motor mouthing this whole time, today we really need to commit to making a meaningful progress. So what are we going to do? I think first we need to define our goal, define our lodestone, which in my mind starts with, as I've said before, a safe and socially just environment. So that means zero tolerance as much as possible in training, at meetings and socio-professional interactions. I'd love for there not to be a whisper network when medical students are looking for residencies or when candidates are looking for jobs. That leadership will make it possible and safe for anyone, no matter their position, to be active in shaping a climate where misconduct is never ignored, minimized, or excused. And we have to be brutally candid about our shortcomings. One of the best words of advice I ever got in residency was to run towards fire. Like at M&M, confronting discomfort, not shying away from complications. Surgeons are not, strangers to that concept. In medicine, we have to diagnose what's happening each time, intervene, and go through a constant cycle of maintenance to try to improve ourselves and our culture. Difficult conversations, we can have those. We have them when we have M&M. So if any of the data or lived experiences I've discussed in this talk are new to you, have some conversation. So what are we diagnosing? Things like implicit bias. If you don't know, Harvard has a project implicit bias personal assessment tool, mapping your privilege. As simple as when you were a kid, did you have a stable home, a non-violent home? Did you have food security? The lights stay on? Understanding socialization, why people assume doctors are men and nurses are women. And because of how we're socialized, sometimes women are not allies to women. Sometimes you may not be an ally to yourself. Susan McKinnon talks about female selective sabotage as a socio-anthropologic phenomenon. And of course, we've all heard of imposter syndrome. The world doesn't like it when women don't fit their expected archetypes. Performing regular diversity audits like culture surveys or annual reports about sexual harassment, and diagnosing denial, of which there are many types. Like what? There's denial of fact. Oh, no, I don't think that's true. Denial of awareness. Oh, I had no idea. Denial of responsibility. Well, that's not my fault. That's not my responsibility. That's like over there, not for me. Or denial of impact. Well, I didn't mean for you to feel that way. It feels easy to give into denial. It's so easy. But we all know that feeling, but we need to do better and hold ourselves accountable. And as we get better at diagnosis, maybe we can even do some classification. It's easy to diagnose the obvious people who are models, sponsors, mentors, allies, people who are most definitely not models, sponsors, mentors, and allies. For people who are aware but not active, we should encourage them to be more active. For people who are not aware and well-meaning, we should start with increasing awareness. The hardest is to see through people who are duplicitous, subtle, or subversive, and that just has to come with practice. Intervention. If we accept the data I presented here today as fact, we must intervene. That includes a commitment to continuous education, honest discourse, well-developed offices of DEI, well-funded offices of DEI, and participants, crosstalk between specialties and leaders, investing in recruitment and retention, saying no to manels, panels with only men because there's no woman that can possibly talk on this topic. And there's now the concept of DEI M&Ms, which was developed on the East Coast. Most of all, we need investment and funding for research, funding for interventions. And most interesting and fun for me is looking outside our specialties, such as the United Nations recommendations, National Institute of Minority Health and Health Disparities, Harvard Business Review. And we need to start generating data for accountability infrastructure, for reporting mechanisms, and for evidence-based practices. What is the current evidence-based practice for academic surgery and diversity? There's very little. So I summed it up in this one article because there's many articles, but in San Diego and NYU, they reviewed 15 initiatives that had proven effective in increasing match rate of women and underrepresented minorities. That included website content, signaling allyship, a more holistic application review concordant with your department's own mission and culture, and finding ways to decrease costs for candidates. There are some higher cost initiatives that are longitudinal support programs, including scholarships and stipends. If you don't know about Nth Dimensions, I really recommend you look into it. It's really, really effective. Their effectiveness is amazing. And so I view that as a model, but it is like 5 figures to take a medical student from first year to like a matched resident. So it is a high cost endeavor. But once you match residents, what about retention and helping them thrive, residents and faculty? And based on the culture and data I've described, changing the work environment is going to be a challenge. I guess one way to look at it is that there's a lot of opportunity here. In Chinese, Wei Ji means crisis, and it combines the character for danger, Wei Xin, and opportunity, Ji Hui, kind of like the Albert Einstein quote, in the midst of crisis lies opportunity. Where there's a void, there's a lot of opportunity, right? So for research, for creativity, like nobody's done X before, so you can only make it better, you know? To draw from other practitioners of DEI to create crossover projects. Like for me, it's been fun working with linguistics professors, with law professors, with technology and psychology. It may feel very overwhelming, but we need to start somewhere, right? We need to start yesterday. We need to recruit and activate more allies and stakeholders along the hierarchy. And we need to remember our why, which is to take care of our patients, but also of each other. And we need the money to do it. And of course, as with everything, constant maintenance is necessary. It took us hundreds, maybe thousands of years to get here. It's not going to fix itself in a few years. So envision for yourself what your ideal work culture and outcome looks like. Sometimes that's really hard because we've been stuck in this box of the old ways. But I think no matter what, everyone deserves to thrive, not just to survive day to day and graduate. And as evidence has shown, when people thrive, you see it in the deliverables. And there's so much farther for us to go in improving our workplace and our patients' lives. So as of today, there's already more women than men in the United States in medical school. And in terms of race, 2030 will be one of the first inflection points of becoming a Caucasian minority country. And so in the timeline of medicine, that is not a lot of time. So 2030 is going to be, if you're an intern now, 2030, you're going to be a chief. That's not a lot of time. What journey should we have accomplished by then? And I hope it will have been a journey of non-passive allyship, stewardship of each of our specialties clinically, demanding high standards of care for our patients, should be paired with stewardship of our specialty as a more inclusive community, which evidence has shown would downstream benefit ourselves, our specialty, and our patients. Leadership is not only about being in charge, but taking care of those in your charge. Change is hard, and there's many stages we have to traverse to get to the other side, as Kubler-Ross here has described, including denial, resistance, and a valley of chaos, okay? It's a really complex thing that we have to go through to accomplish change. There's fear, there's learning, there's growth, and this looks very familiar, right? So let's remember, we're not strangers to this process. We didn't grow by living in our comfort zone. When you look at the circle of people around you, you should feel inspired and challenged and be forced to be better, not complacency and status quo. And as psychologists say, accepting archetypes creates in your mind a psychic prison. Accepting and not challenging archetypes creates in your mind a psychic prison. And again, as I said in the beginning, We are super smart. We're super talented. We can work 120 hours a week, not really. Right? So why can't we do this? Like in micros, when I give this to plastic surgeons, I say, somebody was in their garage inventing microsutures, who was sewing rabbit ears back on, but somehow this, just a human thing, we cannot do. Like, I don't accept that. Empathy is defined as believing somebody and their experience and not how you imagine their experience to be. Once you have empathy for somebody, I don't think it's such a leap to elevate yourself from simple tolerance to statements of support, to actions of support, and speaking up and intervening. What you permit, you promote. What you allow, you encourage. Neutrality helps the oppressor and never the victim. And just as we have persisted to become surgeons who do challenging, crazy, magnificent things in surgery, you know, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But by all means, just keep going. Surgeons are proven innovators. Surgeons are proven innovators. We need only to look at, I'll cherry pick my specialty. The first kidney transplant is plastic surgery, the first free flap, the first wound vac. Like anything that creates evolution, this nuanced path demands investment and persistence. And just as we apply the scientific method to our work, we must be systematic and relentless about our commitment to diversity, equity, justice, and inclusion. So thank you again so much for the opportunity to talk to you today. I'm so interested to hear your perspectives and your discussion. Thank you so much.
We'll start with questions in the room, and I'm also monitoring.